Good morning, everyone. I am Mugi Wahidin from National Research and Innovation Agency, or BRIN, Indonesia. I'm glad to be here to be part of the 5th International Conference on Cancer Science and Therapy in Kuala Lumpur, Malaysia. I'm representing my team of research. I would like to share our work entitled Overview of Breast Cancer Screening Program in Indonesia using clinical breast examination and ultrasonography testing. As a background, the breast cancer is the most common cancer in Indonesia as well as in the world, especially among females. And in Indonesia, the program of breast cancer screening was launched in 2008 by Indonesian First Lady, and now is conducting by all districts in Indonesia. Breast cancer screening program using the clinical breast examination and ultrasonography testing. And of course, the result of this program need to be refilled and to be learned to improve the program. So we conduct the study aimed to overview the program of breast cancer screening using the clinical breast examination and ultrasonography examination. We use a cross-sectional study design using secondary data from the Ministry of Health Indonesia 2024. And we incorporate independent variables, including overweight, obesity, central obesity, and dyslipidemia. And dependent variables are lump in the breast, suspected breast cancer, simple cyst, and non-simple cyst. And the population of the study are all districts and cities in Indonesia which conducting the screening program, including the number of the screening for CBE or clinical breast examination is more than 4 million people, and more than 600,000 people are screened using USG testing. And we use more than 500 districts or cities to be analyzed as sampling of this study, and we use the criteria that the district or cities having the complete data. And in this study, we use the descriptive analysis, comparative analysis using Mann-Whitney test, correlative analysis using Spearman correlation test, and also we use the district as unit analysis. Ladies and gentlemen, this is the result of our study. In the descriptive analysis, we understand here that majority of the samples was from west part of Indonesia. It's about 64%. And majority the samples are from districts, more than 80%. And from this table, we understand that the result of the screening shows us that more than 6.1 per mil, or more than 21,000 cases, are lump in the breast. And we found 0.33 per mil, or more than 700 cases are suspected of breast cancer. And from ultrasonography testing, we found that 1.1 per mil simple cyst and 3.1 per mil non-simple cyst. I think it's a big number, especially from a country like Indonesia. And then the other results shows that there was no difference between West and East Indonesia in terms of lump in the breast, suspected breast cancer, and simple cyst. But there is a difference between West and East of Indonesia in terms of simple cyst. And the other results, we can see here that there was no difference of the lump in the breast, suspected breast cancer, simple cyst, between district and cities in Indonesia. It is a comparative analysis. The other results, the correlative analysis, shows here that there was a positive correlation between overweight, obesity, central obesity, and dyslipidemia, and the lump in the breast. I mean, this is the determinants of lump in the breast in Indonesia we found from this study. It's similar with the risk factors of breast cancer, actually. And from this analysis, we also know that there was no positive correlation between the risk factors or the determinant with suspected breast cancer, simple cyst, and non-simple cyst. And from the result, we discussed that the breast cancer screening program in Indonesia become a written program. As I stated, it started in 2008 to diagnose early of the breast problem. I mean, this program is running to detect lump in the breast, suspected breast cancer, simple cyst, and non-simple cyst as well. And the program needs to be expanded to cover more women as target of the government is aged 30 to 49 years old in the west and east of Indonesia and across all districts and cities. Because there is no difference between west and east and district and cities in Indonesia. And breast problem found in the program should be followed up by the appropriate diagnosis and treatment in health facility. As we know that more than 6 per mil of lump in the breast need to be referred to the hospital to detect which is if it is cancer or not, and so it needs the treatment in the health facility. And determinants of the lump in the breast, including overweight, obesity, central obesity, and dyslipidemia needs to be controlled. Because if we would like to control breast cancer, we should control these risk factors. And as a conclusion, the positive cases of breast cancer screening was quite high in Indonesia, taken from the breast cancer examination and ultrasonography testing. In general, there is no difference between west and east and district and cities on the breast cancer problem, especially except on non-simple cyst. Non-simple cyst, there is a difference between west and east of Indonesia. And the determinant of lump in the breast includes overweight, obesity, central obesity, and dyslipidemia. So it needs to be controlled. And it needs to develop the follow-up program following the screening, to manage the breast cancer earlier, especially the follow-up program for lump in the breast and suspected breast cancer. Thank you very much.
Good morning, everyone. I'm Dr. Nurhan Barawi from Tropical Medicine, Gastroenterology and Hepatology Department, Ain Shams University, Egypt. Today, I present our published work entitled Serum-derived circular RNA as a diagnostic biomarker in non-hepatocellular carcinoma, chronic liver disease, which is actually a phase 2 cross-sectional study. This study evaluates the potential role of serum-derived circular RNA as a non-invasive biomarker for chronic liver disease diagnosis and monitoring. Chronic liver disease is a major global health burden and may progress to fibrosis, cirrhosis, and subsequently HCC. Although liver biopsy remains the gold standard for diagnosis, it's invasive and not always well tolerated. Therefore, there is a growing interest in non-invasive biomarkers. So circular RNAs are stable non-coding RNAs found in serum and tissues. Their stability and disease specificity make them promising diagnostic biomarkers in the hepatology field. So the aim of our study was to evaluate serum-derived circular RNA as a diagnostic biomarker for chronic liver disease patients without hepatocellular carcinoma. We also aim to assess its relationship with inflammatory and fibrosis markers, and also comparing expression levels among healthy controls non-HCC chronic liver disease patients and chronic liver disease patients with HCC from our previously published phase 1 study. This was a controlled cross-sectional study conducted at Ain Shams University hospitals. The study included 30 non-HCC chronic liver disease patients and 30 healthy controls. Blood samples were collected for serum extraction, RNA extraction, DNA synthesis, and PCR analysis, and expression levels were quantified using delta-delta CT methods. As we see, this slide summarizes the baseline characteristics of our patient cohort. Most patients were female overweight. Major etiologies include viral infection, hepatitis C, and steatotic liver disease. Many patients also demonstrated advanced liver disease manifestations as ascites, jaundice, and features of hepatosplenomegaly. As we see here, this figure demonstrates a strong positive correlation between circular RNA and liver severity scores, CTB scores, and also who will check the paper published, there also strong positive correlation with inflammatory markers or scores as neutrophil lymphocyte ratio, suggesting that elevated circular RNA levels may reflect systemic inflammatory activity and liver disease severity in chronic liver disease patients. One of the key findings of our study was that serum circular RNA were significantly elevated in chronic liver disease patients compared to healthy controls with a highly significant p-value. And so these findings support its potential role as a sensitive, non-invasive diagnostic biomarker. This slide summarizes the major laboratory correlations observed in our study. As we see, circular RNA showed strong positive correlations with bilirubin, neutrophil lymphocyte ratio, platelet lymphocyte ratios, and even AST levels. And these findings indicate close association between circular RNA expression, liver dysfunction, and inflammatory activity. As a relationship with disease severity, we also found that higher circular RNA levels were associated with more advanced disease severity. Patients with high child Bow and mild scores demonstrated significantly increased circular RNA expression. Additionally, elevated levels were observed in patients with ascites and hepatic encephalopathy, reflecting disease decompensation. This slide summarizes the fibrosis scoring systems used in our study, including FIB4, APRI, and NAFS score. Most patients demonstrated significant fibrosis and also cirrhosis according to these non-invasive fibrosis markers. So these results further confirm the advanced liver disease burden in our patient population. This ROC curve demonstrates excellent, actually, diagnostic performance of circular RNA in differentiating chronic liver disease patients from healthy controls. As we see, the area under the curve reached 0.97, indicating even to us an outstanding diagnostic accuracy, as the cutoff value of 2 circular RNA achieved nearly complete sensitivity and around 90% specificity, meaning that the biomarker actually was highly effective in identifying diseased patients while maintaining low false positive rate. And so these findings strongly support its potential clinical utility. And so as a stepwise increase across disease spectrum, this slide demonstrates gradual increase in circular RNA expression across the liver disease spectrum. As we see, healthy control showed the lowest levels, followed by non-HCC chronic liver disease patients, while chronic liver disease patients with HCC demonstrated the highest levels. And so this pattern suggests a potential relationship between circular RNA expression and disease progression. By comparing chronic liver disease patients with HCC and those without HCC, this comparison highlights important biochemical and prognostic differences between HCC and non-HCC groups. As we see, HCC patients showed significantly higher alpha-fetal levels, inflammatory markers. Meanwhile, non-HCC patients demonstrated more advanced fibrosis and liver dysfunction scores. This slide summarizes the major laboratory correlations observed with circular RNA expression. Strongest correlation were observed with bilirubin, neutrophil lymphocyte ratio, platelet lymphocyte ratio, and so these findings reinforce the role of circular RNA as a marker of both hepatic dysfunctions and systemic inflammation. Our study has several important strengths. It's among the few studies evaluating circular RNA, specifically in those without HCC chronic liver disease patients. In addition, we integrated molecular inflammatory fibrosis and prognostic assessments to comprehensively evaluate biomarker performance. However, our study also had some limitations. The relatively small sample size, longitudinal follow-up wasn't available, so future multicenter studies with larger cohorts and serial monitoring are needed to further validate these findings. These findings suggest that circular RNA may potentially serve as an early diagnostic biomarker and also a monitoring tool for disease progression and a marker reflecting inflammatory activity and liver dysfunction, which may improve, of course, as we know, the non-invasive assessment and follow-up of chronic liver disease patients. Future research should focus on large multicenter validation studies, longitudinal monitoring of circular RNA expression, comparison with elastography and advanced imaging techniques, exploring potential therapeutic and prognostic applications, particularly in the era of artificial intelligence. So in conclusion, serum-derived circular RNA is significantly upregulated in chronic liver disease patients with or without HCC. It demonstrates excellent diagnostic accuracy. Its expression correlates with liver dysfunction, inflammatory severity markers. Therefore, circular RNA represents a promising non-invasive biomarker for early diagnosis and monitoring of chronic liver disease. That's a key take-home message to everyone. And lastly, I'd like to sincerely thank my supervisors, colleagues, Tropical Medicine Department and Shams University, Egypt, and my family, Dr. Barawi and Dr. Lobna, for their continuous support and guidance. I'd also like to thank organizers, scientific committee, and all attendees for organizing this valuable event and
Good morning, colleagues. I'm Dr. Mohan Babu from RIMS Imphal, Northeast India. Today, I present our 8-year retrospective study on early versus late onset colorectal cancer, recently published in the Journal of Carcinogenesis in 2025. This work fills a critical gap. No prior study had examined this in Northeast India, a region with distinct dietary habits, genetic background, and the highest colorectal cancer rates in India. I will walk you through 6 sections: the global and the Indian burden, why this study matters, our methodology, results in 2 parts, discussion with literature comparison, and conclusions with future directions. Moving on to the introduction, let me set the epidemiological stage. Colorectal cancer is the 3rd most common cancer worldwide, and it is the 2nd leading cause of cancer deaths at 9.4%. In India, it ranks 4th as per NCRP 2020. But look at the Northeast India. Mizoram has the highest age-adjusted rate in India at 12.2 per lakh in men. Manipur's Imphal West district records 7.8 per lakh in men. These numbers are not just statistics. They represent a population with distinct cultural and dietary habits, fermented foods and smoked meats. RIMS Imphal is a primary regional cancer center serving this population. So why did we conduct this study? Globally, colorectal cancers are once a disease of over 60s, but it is rising sharply in adults under 45 at present. These young patients present at advanced stage with aggressive biology and poorer prognosis. India mirrors this trend driven by urbanization and dietary westernization. But here is the gap. 2026 update shows CRC incidence is rising 3% per year in adults aged 20 to 49, and 45% of new colorectal cancer cases now occur in patients under 65, which is more than the significant number which was done in 1995. Now let me move to the second section, that how we conducted this study. We conducted a retrospective observational study at the Regional Cancer Center, RIMS Imphal, the primary cancer facility serving this population. We reviewed 352 CRC cases over 8 years from 2013 to 2020. Age ranged from 14 to 92 years with a mean of 53.3. We defined early onset as under 45 years, which includes 117 cases representing 33.2% of our cohort. Late onset was over 45 years, that is 235 cases at 66.8%. Staging followed year was AJCC 8th edition. Statistics used was IBM SPSS version 26, and significance was considered at p-value less than 0.05. Section 3 includes the results, which is divided into two parts. There, part 1, let us see who are these patients and how did they present to us. Table 1 shows a demographic and risk factor comparison. Key findings are: first is gender. Unlike most Indian studies showing male dominance in early onset colorectal cancer, we found slight female preponderance at 51.3%. This is unique to Northeast India. Second, BMI. Overweight and obesity was significantly higher in early onset patients, 35.9% versus 25.1%. And p-value is also 0.008, which is significant. This aligns with global data linking adiposity to colorectal cancer risk. Third, comorbidities like diabetes and hypertension were significantly more prevalent in late onset patients as expected. However, smoking and alcohol showed no significant difference between these two groups, contrary to some global reports. This reflects distinct cultural consumption patterns in Northeast India. Moving on to the next slide. Thus, this slide shows the clinical presentation. Here, the first one you are seeing is the bleeding per rectum, and the green color is early onset, that is less than 45 years, and this blue colored bar diagram is late onset of more than 45 years. Weight loss was strikingly more common in late onset, that is 51.1% versus just 12.8% in early onset. This suggests late onset patients present with more constitutional symptoms. However, abdominal pain was slightly more frequent in early onset at 35% versus 30%. Moving on to the results, part 2. The biology of these tumors, where they are located, how advanced they were at diagnosis, and what CEA told us. Now we come to the histopathology, and this is where the biology tells a compelling story. Early onset CRC was significantly more aggressive. Signet ring cell carcinoma, it's one of the most lethal subtypes. It occurred in 14.5%. Here in this first diagram, here in this first bar diagram, you can see this 14.5%. This 14.5% is the signet ring carcinoma in the early onset, whereas it is only 2.9% in late onset. So early onset has more aggressive histopathology. Similarly, this number 3 is 10.4% was mucinous adenocarcinoma, whereas only 0.9 was present in late onset. This is late onset, this 10.4 is early onset. So this 10.4 and this 14.5, both are significantly more in early onset group. And the histological grade, poorly differentiated tumors. This is number 3 is poorly differentiated tumors. This poorly differentiated tumors indicating high grade and aggressive disease were found in 28.2% in early onset. whereas it is only just 8.5% of late onset patients. All these differences were statistically significant. This is not merely a matter of age. This suggests distinct tumor biology in young onset colorectal cancer. Regarding tumor location, the rectum and sigmoid colon dominated in both groups, 67.5% in early onset and 69.7% in late onset. This is that rectum and colon group. However, this was not statistically significant. However, right-sided colorectal cancer was slightly higher in early onset patients at 22.2% versus 19.5%. This aligns with global young onset data where proximal tumors are more common. It contrasts with other Indian studies from Chhattisgarh and Pan India series. This bilateral distribution in Northeast India, both left and right-sided involvement, may reflect unique dietary and genetic influences in our population. Moving on to the next slide, staging, it revealed a concerning pattern that is 31.6%. 31.6% of early onset patients presented at stage 4. This is stage 4. So this is early onset and this is late onset. 31.6% presented with stage 4 at the time of presentation, whereas only 26.3% was present in late onset. So young patients are arriving with more advanced disease, and serum CEA levels showed an interesting paradox. While late onset patients had higher rates of elevated CEA, 60.9% versus 51.12%. This difference was not statistically significant. One might expect the more advanced early onset group to show higher CEA. This paradox, also noted by Arnaud in historical literature, may reflect genuine biological differences in tumor marker expression between age groups. Or it may suggest that CEA alone is insufficient for early detection of young patients. So let me summarize the key results at a glance. 1/3 of all colorectal cancers at our center was early onset. Signature carcinoma was 5 times more common in young patients. Poorly differentiated disease was over 3 times more frequent. Advanced stage presentation was higher in the young, and obesity was a significant and modifiable risk factor. The message is clear. Young Indian adults, particularly in Northeast India, are not immune to aggressive colorectal cancer. Moving on to the next section, this discussion, how do our findings compare with the world already knows? The female preponderance we observed contradicts the male dominance reported by Sudarshan in Chhattisgarh and Nath's Pan India series. This is a distinct Northeast India finding and it warrants further investigation, whether genetic, hormonal, or related to healthcare seeking behavior. The BMI association is consistent globally. The metabolic link between obesity and colorectal cancer is well established, and our data reinforce that weight management must be a part of primary prevention even in the young adults. Smoking and alcohol, surprisingly, were not different between these groups. In Northeast India, there are culturally ingrained habits across generations. This does not mean they are harmless. Rather, their carcinogenic effect may be uniform across age groups in this population. Comorbidities like diabetes, hypertension were significantly more in late onset, consistent with metabolic syndrome CRC link. That is that carrying meta-analysis. Our histopathological finding strongly aligned with global literature. The anatomical location pattern, both left and right-sided involvement, distinguishes Northeast India from other Indian studies and somewhat aligns with globally right-sided trends. This has implications for screening. Flexible sigmoidoscopy alone may miss significant proximal disease in our young population. The advanced stage at diagnosis is consistent worldwide. Young patients experience delayed diagnosis because neither they nor their physicians suspect CRC. The CEA paradox remains intriguing. If CEA is less sensitive in young patients, we urgently need novel biomarkers to calculate the circulating tumor DNA microRNA panels for this demographic population. This table summarizes our study against key Indian and global benchmarks. Our early onset proportion of 33.2 sits with the global 25 to 40% range and aligns closely with Sudarshan's 35 to 39% and Nat's 35.5%. However, the gender pattern, tumor location, distribution, and the magnitude of histological aggressiveness mark Northeast India as epidemiologically distinct. The message is not that Northeast India is an outlier, but that India is not epidemiologically homogeneous. A screening policy designed for Gujarat or Tamil Nadu may fail in Manipur or Mizoram. We need region-specific guidelines. So, moving on to the next section, that is conclusion and future directions. What should we take away from this study? Let me conclude with 5 key messages. First, early onset colorectal cancer constitutes 1 in 3 cases at our center, a significant and rising burden. Second, positive family history confers higher risk for early onset disease. Genetic screening for Lynch syndrome, BRCA mutations, and familial adenomatous polyposis, FAP, must become standard of care. Third, early onset disease shows histologically distinct, more aggressive biology. Signatoring mucinous and poorly differentiated subtypes dominate in early onset group. Fourth, young patients present at more advanced stage, a direct consequence of delayed diagnosis and low index of suspicion. Fifth and finally, a index of suspicion is essential for any young Indian adult presenting with persistent gastrointestinal symptoms. Age must never be a barrier to investigate, and critically targeted genetic and dietary studies in Northeast India are urgently needed to inform effective population-specific screening policy. Where do we go from here? Our study opens 5 avenues. One is genetic and epigenetic profiling, identifying hereditary mutations in this genetically distinct population. 2. Dietary analysis, quantifying the impact of traditional Northeast diets, which includes fermented soybeans, smoked pork, red meat consumption, etc., and their interaction with the gut microbiome. 3. The novel biomarkers, moving beyond CEA to circulating tumor DNA and microRNA panels for early detection in adults. 4. Is long-term survival studies, prospective follow-up to optimize treatment protocols, specifically for young onset biology. 5. A multi-center Northeast in Northeast India predilection, distinct from rest of India due to cultural and dietary differences. These are my references. And we have conducted this study in Regional Cancer Institute Department of Radiation and Oncology in RIMS, Imphal, Manipur. And these are my co-authors, Dr. Laishram Natasha, Dr. Laishram Purnima Devi, Dr. Gautam, Dr. Falguni, and Dr. Farhana. Thank you.
So, I am presenting a case report on oral squamous cell carcinoma. I am trying to basically convey a strong message so as to what immense miracle, prompt treatment and spontaneous or very early diagnosis is going to aid to facilitate a better life to a person. So there was this female patient who came to us with burning sensation in the gingiva. Hello? Hello?
Yes, yes,
Hello?
Dr. Lumpur.
Yes.
Carry on, carry on.
Yeah, so there was this patient who came with us with a chief complaint of burning sensation in the mouth, especially in the gum area. So we gave her a simple treatment. We just gave her a topical ointment, and we told her that she has to apply some ointments also and take some supplements of vitamin B complex. After probing a lot, we somehow suspected that she is hiding something from us. And then after we forced a lot, in the end, she told that she has a history of consumption of betel nut and tobacco. So these are some intraoral pictures of the patient, which typically explains that there is so much of recession in the gingiva with excessive amount of erythematous bands also. Like you can see a lot of pinpointed punctured outgrowth of some ulcers and some vesicles which are seen everywhere. So she was very, very reluctant, but still we forced her to get some investigations done. And then she was even reluctant to show her intraoral picture. If you can see in next slide, if it's properly visible, her tongue, classically very, very patchy, like a geographic map appearance of, a lesion which is trying to invade and encroach and go deeper into the tissues. That classic configuration is appreciated over there. And then we figured out that this lesion is not a simple one. It is something which is proliferative in nature. So we came up with a provisional diagnosis of proliferative leukoplakia. Now, leukoplakia or leukoplakia is a patch, or erythroplakia is a patch, which is a non-scrapable white patch. Now, this was a mixture of red and white both. So we came up with a provisional diagnosis of proliferative verrucous leukoerythroplakia. So it was a mixture of red and white patch both, along with some geographic tongue-like areas also. We also did a lot of toluidine blue staining also to her, and that also has shown that this has been there. Those particular lesions have taken up a stain. Very, very hesitant again to share her complete history. She said, I have this habit of consumption of tobacco and nicotine only since 5 to 8 years, but we were somehow not very convinced right up to the end. So we kept telling her, we kept insisting that you should keep coming to us once in 3 months or once in a month ideally. But nai, I am good. She kept telling that. And just look at the lesions, just look at the immense stain that the person has taken up. That's all the blue toluidine stain which is absorbed. So we did a histopathology of the same, and histopathology also has shown a proliferative nature. The epithelium is, going slightly deeper. It appears to be going into the connective tissue, which itself is a bit of a suspicion. It indicates that the epithelium is proliferative in nature. Along with that, we see in the connective tissue, we see mild to moderate dysplastic changes. Like we see all the features of epithelial dysplasia, moderate to high grade epithelial dysplasia we have seen. And that lesion is suspicious, that it suggests that this is heading towards a malignancy. And then we took some more pictures of the same. Then we just thought that this is, over and she should be fine. And then after some time, she just accidentally happened to come to us. And then the things that we saw was huge. Even this thing also, radiographically also, so much of destruction of everything. The bone loss is there. So much of the teeth actually appear as if they are floating into the this thing. And then afterwards she came up with a full-blown lesion, and we had to undergo she had to undergo a hemimandibulectomy, and so many a subtotal incision was there. She till the end did not show, she was not ready to come up to us, and that's how her entire mandible she had to sacrifice. So in that we could see that her entire mandible is chopped off, and so much of pieces of soft tissue, so much of pieces of hard tissue have gone. There was this lymphadenopathy. Her lymph nodes were extremely tender. Her lymph nodes were very, very palpable. And she had to just sacrifice her entire mandible for that. She had to undergo a hemimandibulectomy. And then after that was done, we had to take a histopath of the same. And then in the histopathology, we saw that there is a well-differentiated oral squamous cell carcinoma. In the histology, we saw a proper keratin pearl formation. We saw lots of inflammatory cells. We saw a proper breach in the connective tissue, in the epithelium, rather the epithelium entering very aggressively into the connective tissue, a highly blown lesion, just pure negligence. and it led to a formation of a high-grade oral squamous cell carcinoma. It is said that in comparison to poorly differentiated variant, well-differentiated squamous cell carcinoma has a bit of better prognosis, but then any cancer is a cancer at the end of the day. At least at the sake, at the cost of sacrificing your own mandible. So just by if the person would have told us that that she has this habit of consumption of alcohol, tobacco, ganja, and so many other things, betel nut chewing and all, we would have taken those drastic steps in the earlier stages itself, and we would have tried to save this pre-malignancy getting converted into a malignancy. So this is a case which reflects that pre-malignancy, the rate of any pre-malignant lesion or pre-malignant condition getting transformed into a frank oral squamous cell carcinoma is quite high, especially if it is a red lesion. These rates are even more higher. All the red lesions, as their names, they appear to be fiery, scary, and their rate of malignancy transformation is also high. Nowadays, oral squamous cell carcinoma is a multifactorial process wherein not just habits, but a lot of genetic, epigenetic changes are responsible for that. But then things which are under our control, things which we should strictly avoid, even if we are able to successfully take care of those, I think we have almost one half of the battle. Despite all this, if it's going to happen, then nothing can stop that. But these things, like I doubly, triply repeat, prompt treatment, and before that, early diagnosis, absolute transparency of the patient to the doctor is absolutely essential. So this is what I am trying to say, that none of the it basically starts from an ulcer. That's the earliest thing. The funny part in oral cancer is that the patient is not having any pain, and this is this mindset that unless there is pain, nobody will approach the dentist or nobody would approach the dental surgeon. So this ulcer, it starts with a small little ulcer, but we should all take care, or we should all note here that any ulcer which is not healing for more than 8 days, definitely it requires some kind of a treatment, or some kind of a note to be made. So this is what I'm trying to suggest from my presentation. Thank you so much.
Yes?
Yes.
Okay, thank you. Thank you very much. Okay, can you just move to the next slide, please? Thank you for inviting me here to speak and present my work. And I'll be speaking about music intervention, based interventions as a supportive approach for stress regulation in cancer care, particularly from a psychoneuroimmunology and biobehavioral perspective. So, if speaking about stress, next please. Cancer is not only biological disease, but also a major source for chronic psychological and physiological stress, which affects patients throughout diagnosis, therapy, and survivorship. Consequently, the stress management is increasingly recognized as an important component of integrative and supportive oncology care. Next, please. So chronic stress activates two major biological stress systems, and that is hypothalamic pituitary adrenal axis and the sympathetic nervous system. This activation increases control cortisol and catecholamines such as adrenaline and noradrenaline, and these mediators can influence tumor biology through several mechanisms, including suppression of immunosurveillance, particularly natural killer cells activity, as well as increased inflammation, angiogenesis, and metastatic potential. as we see in vitro studies. So next one is about, next slide, please. So experimental findings tell us that we have this support with these associations. Noradrenaline has been shown that increases cancer cell migration in vitro studies, and beta-adrenergic simulation enhances metastasis process in animal models. These findings suggest that stress is not only physiological, but it has direct effect on tumor behavior through neuroendocrine immune interactions. And the next, please. So there is a question whether stress modulating intervention may also influence these pathways. And systematic reviews shows that reviews and meta-analysis, of course, show that music-based intervention can significantly reduce psychological stress and anxiety, and also improve physiological stress markers such as cortisol, heart rate, and blood pressure. And next, please. So beyond subjective effects of music intervention, appears that influence biological system involved in psychoneuroimmunology. Research shows that there is effect on this one interventions on cytokines activity and lymphocyte responses through modulation of brain, endocrine, and immune pathways. This support the idea that music-based interventions act as a behavioral modulation rather than purely psychological interventions. There's research that shows that or it is receptive participation in music intervention, or it's active. It has a positive response from human behavior. And particularly, it has been shown that there is stronger effect in active group music, for example, in choir, when you're participating by singing. And that indicates multi-system regulation from endocrine to and immune systems. So on the next part, please. Yeah. So as following, music-based intervention influence cytokines and lymphocyte activity. And the mechanism is actually this one of brain endocrine immune pathways I said before. So it supports bio-behavioral mechanism of action. And the next, please. In the recent large systematic review, which involves 9,000 participants and approximately around 119 randomized clinical trials, it was found that music-based interventions were more effective than standard care in reducing cancer-related pain, in fatigue and distress, with the strongest evidence from symptom reduction in the studies and improvement in patient experience. And the next, please. They have been seen pain reduction, significant reduction, especially peri-procedural period, and also improved were anxiety and quality of life, but the findings were heterogeneous, and outcomes appear to be influenced by music type intervention, by its duration, by patient preference in music style, and on the whole, the intervention design. So there is no standardized protocols for these interventions, which need to be taken in account in the future. And then next, please. Regarding pediatric and adolescent oncology, there is an extensive systematic review which says that music interventions like music therapy and music listening, which is different than music therapy, demonstrate reduction in both subjective and physiological, subjective and physiological anxiety. Subjectively, we're speaking of increasing quality of life, reducing pain and social isolation. And of course, physiologically speaking, we had the review shows that it had reduction in heart rate and respiratory rate. The other findings were inconclusive, like mood, coping, and immune outcomes. Next, please. Meta-analysis in patients receiving chemotherapy found significant reduction in anxiety along with modest improvements in quality of life. And effects on depression level were consistent, again suggesting that anxiety reduction may represent the most robust clinical outcome, but not on depression. They were inconclusive. So the next, please. So neurologically speaking, music engaged multiple systems simultaneously, emotional, reward, and autonomic circuits. And neuroimaging studies show activation of brain regions such as the amygdala, which supports the real-time emotional and physiological regulation. And the next, please. So we can see on this one slide that from the left, the intervention that are cognitive behavioral therapy and mindfulness-based interventions, positive psychological intervention. They involve mechanisms like cognitive control from prefrontal cortex, attention regulation, cognitive reappraisal, and emotional regulation. At least these interventions are aiming at this. On the left hand, the last one, column, we can see that intervention-based, music-based interventions have a very similar mechanism, but it starts from auditory processing, going to limbic activation, which is emotion, reward system, which is increases dopamine, and autonomic regulation, both sharing the same structures of the brain, like prefrontal cortex and limbic system and reward circuit and stress system, as on both major systems of stress. So the clinical outcomes in both coming like decreasing stress and anxiety, increasing emotional regulation, increasing cognitive flexibility, and increasing well-being and quality of life. We do have different pathways, shared neurobiology. So cognitive music complements this cognitive-based intervention through integrated brain network modulation. And the next, please. Of course, there is limitation in the current evidence. We have heterogeneity of interventions. There is a wide variation in music type, duration, and delivery, passive or active. For example, I'm playing musical instrument, or I'm just listening to the music. Methodologically speaking, there is limitation like small sample sizes in several studies. There is variability on outcome measures and not actually standardization of protocols. There is inconsistent biological findings and mixed results for imminent markers, mood and depression outcomes. And the next, please. The limited evidence. Okay. Yes. Limited evidence suggests that there is tumor-specific outcomes, mechanistic pathways, and there is not actually supportive evidence for that. Just few studies integrate both biomarkers and clinical endpoints. And in general, we can say that music-based interventions show strong effects on stress and symptoms, but there is no direct effects on tumor biology still, which remains to be investigated. And the next, please. So music-based intervention act on multiple levels, from emotional experience to brain circuits and immunoregulation. These multi-level effects indicate that this kind of intervention may offer meaningful clinical value as low-risk supportive intervention for stress management in cancer care, which guaranteed further targeted research and clinical integration. I think that that's all. My presentation. Thank you very much for your attention.
Good day, dear colleagues. Let me introduce you our experience in treatment of such rare metastatic site of melanoma as poplittle lymph nodes. As I said, poplittle fossa is one of the rare agents for location of melanoma metastasis, along with metastasis in cubital region or lumbar triangle. The most common region for lymphogenic metastasis in lower limb is groin and femoral regions. But with the development of frequency of sentinel node biopsy, the frequency of poplittle nodes involvement also increase. According to different articles to literature review, the frequency of poplittle nodes involvement in lymphatic drainage varies from 0.3% to 20%. The average frequency is about from 2 to 3%. Usually there are from 2 to 9 lymph nodes in poplittle fossa, and in most cases, according to sentinel node biopsy data, they do not involve in full lymphatic drainage. They lie superficially to fascia, and we didn't see them when we make the sentinel node procedure. But in rare cases, it may become clinical significant when nodes lies deep to the superficial fascia. The most frequent locations of the primary tumor in these situations are the heel region. Also, according to literature review, some authors describe such regions like in the Achilles tendon region, the posterior surface of the lower leg, the plantar and lateral regions of the foot. These sites of lymphogenic metastasis usually associated with venous vena parva anatomy. It is assumed that metastases spread along it from its drainage zones. Here we can see the illustration of these zones. In our experience, there were only 3 patients for which we made the poplittle dissection, and all 3 patients had primary tumor in heel region. In this table, we can see that the larger the sample the researcher described, the fewer cases of involvement in lymphatic drainage were found. And author which research about 4,000 patients then make the conclusion that only 0.3% of them had the involvement of poplittle nodes in lymphatic drainage. In this according to some data from article, this is the schematic illustration for lymphogenic metastatic variations. As we can see, they can spread either alternately to the poplittle and then groin area, or simultaneously to both areas, to poplittle and groin area. In 3 cases we described, both variants were observed. Tactics regarding the treatment of metastases in the poplittle nodes are similar to those for any other location. If clinically significant lymph nodes are detected, poplittle lymph node dissection is then indicated. The classic version of poplittle lymph node dissection technique was described in 1980s. We used the technique described by Teixeira in 2014s. The patient lies horizontally on his belly. Then the operation starts from Z-shaped incision or S-shaped incision, and separation and fixation of skin flaps. The incision makes from lateral edge of popliteal fossa to medial because of nerve's anatomy, because the first main structure which we should prepare is the common peroneal nerve, and it lies superficially in the lateral edge of popliteal fossa. The next step is to open the fascia along the borders of the popliteal fossa, and as I said, the first border is the lateral edge with musculus biceps femoris. In the lower edge of popliteal fossa, we ligate the venous of vena parva, where it flows the popliteal fossa. Then the first structure which should be identified and prepared is common peroneal nerve, which is passing superficially near the musculus biceps femoris. The next step is to separate tissue along the common fibril nerve upward to its origin from the sciatic nerve, and where the tibial nerve could be then visualized and also prepared. The next step is to remove all the tissue with lymph nodes along two nerves, tibial nerve and common peroneal nerve, and all muscles, and preserving the popliteal artery and popliteal veins, which lies between two nerves. Also, the most mass of lymph nodes and tissue lies between these two nerves. Here we can see the final result. Fingers separate tibial and common peroneal nerve, and here there is popliteal vein with ligated venous of vena parva, and here there is popliteal artery. In 2 cases we use 2 drainage system, and in 1 case we use only 1 drainage. It usually holds about from 5 to 7 days, and the wound closed with only interrupted skin sutures. As I said earlier, in our practice there are only 3 patients because of rare region for melanoma metastatic site. So all of them had primary tumor in Hill region. All of them was wild type according to BRAF mutation. 2 patients also had simultaneously wide excision of primary tumor, and one patient also had a inguinal metastasis. So simultaneously we make them groin dissection combined with popliteal dissection and wide excision of primary tumor. In conclusion, I should say that there are no standards or recommendations of treatment for poplittle node metastasis. Indications for poplittle node dissections are similar to any other location of local regional melanoma metastasis, and indications for drug adjuvant therapy are similar for all other sites of local regional metastasis. In our practice, all 3 patients had a very poor prognosis. That's all.
Again, good morning. I'm glad to be here today with you. I'm Dr. Iman Al-Mahous, consultant radiology and women's imaging Security Force Hospital in Dammam. My talk will be around breast calcifications and mammography, diagnostic challenges, and workup strategies. The objectives: introduction to various types of microcalcifications, biopsy management, and we'll go through provide practical approach to each type, image-guided percutaneous breast biopsy, workup management strategies, and then understanding calcifications and the pathology report. Introduction: breast calcification seen in mammography often represents difficult, complex diagnostic challenges. These calcifications are more difficult to detect, sometimes analyze and biopsy than other mammographic abnormalities. Mammographic calcification, very important feature for invasive DCIS. The detection of high-grade DCIS prevents development of high-grade invasive breast carcinoma and then so save lives. The value of diagnosing low-grade DCIS is less clear, as significant proportion of these lesions would never become invasive in the woman's life. So microcalcification frequently seen could be benign in the ductal stromal vascular or ductal if it is lobular calcification that might be malignant. The approach to microcalcification is very important, changing over time, the location, morphology, and we'll elaborate around the distribution. The workup includes the looking to prior studies, magnification views, craniocaudal, lateral, doing spot magnifications and compressions. However, digital zooming is not acceptable in reading. These are the routines: mediolateral oblique mammogram view and craniocaudal objections, where you can see the focal asymmetry in the right breast associated the suspicious calcification. On a spot compression magnification, it is elaborate more obvious the distribution of the microcalcification. So how to obtain this and to confirm this shape of microcalcification? By obtaining the mediolateral oblique on 90-degree, the lateral magnification of microcalcification will demonstrate the beautiful teacup appearance, indicating benign etiology. If it's not, then it's either indeterminate or malignant calcifications. The distribution of morphology for these calcifications, including grouped, clustered with its multiple calcifications occupying small volume, less than 1 cc in a tissue, linear, where they are arranged in lines, segmental, they are worrisome for ductal distribution, regional, scattered, and large volume breasts, not confirming ductal distribution, and diffuse scattered distribution randomly through the breast, indicating benign process like sclerosing adenosis. Changing over time, the stability over 2 years in favor of benign etiology. Morphology and distribution should be taken in account with the stability. Biopsy might be considered based on the morphology despite of stability sometimes. Because of the stability of indeterminate, suspicious microcalcification is unreliable for exclusion of diagnosis of malignancy. And remember the location: whenever it's in SNI, it's round, fine clusters, ductal or periductal origin, it's linear. So the typical benign calcifications includes, and not limited to, lucent center dermal calcification, vascular origin, dystrophic calcifications, root-like stromal, periductal, eggshell or oil cysts, coarse popcorn calcifications. And these are the example for root-shaped calcification, vascular, typical skin dermal calcification, fibroadenoma with popcorn calcification, and dystrophic calcification. The typical benign round punctate calcification, usually uniform round, less than 0.5 millimeter distribution, is very helpful to determine the punctate type. Baseline and mammogram, to see it first, you need to call back for magnification images and to advise for a short-term follow-up in a 6 or 12 months interval. If previous mammogram available, compare, and if it's increasing or new, then you might consider a biopsy, a stereo biopsy. If it is stable, a routine screening is advised, and this is labeled as BI-RAD2. If it is a typical benign like this image. The indeterminate amorphous type of microcalcification, it has distinct margins, about 18 to 20% malignancy, bilateral and diffuse usually has a benign entity, clustered or linear segmental distribution definitely has a high risk of malignancy. The differential diagnosis for this type of amorphous calcification includes columnar lesions, fibrocystic changes of the breast, sclerosing adenosis, atypical ductal hyperplasia, atypical lobular hyperplasia, LCIS, and ductal carcinoma in situ. The indeterminate coarse heterogeneous calcification grouped usually smaller than the dystrophic type of calcification. The differential diagnosis would include involuting fibroadenoma, papillomas, fibrosis, and again fibrocystic changes. The highly suspicious fine pleomorphic calcification more conspicuous than amorphous, fine and coarse heterogeneous. 86% they are malignant, often represent high-grade DCIS. The diagnostic challenges, malignancy mimicking, early stage of fat necrosis like sclerosing adenosis, and even certain benign facts like deodorant powders can appear suspicious on initial screening images without prior mammogram. Imaging overlap benign calcifications like those involuting in fibroadenomas may initially appear as a small or regular suspicious before maturing to the classic popcorn-like, which is the benign form. Morphology versus stability, while stability more than 2 years, typically suggesting benign etiology, approximately 25% biopsy-proven malignancy can remain stable for up to 63 months, making morphology more critical factor than stability alone. Detection in a dense breast, dense fibroglandular tissue can also obscure mimic calcification, often requiring supplementary imaging like breast ultrasound or contrast-enhanced mammography for clear characterization. This is the approach, as we mentioned, whether it's a new or stable benign calcification, when to do the biopsy and when to leave it alone as BI-RAD2. So the BI-RAD assessment and the report for radiology is very important to label important for the physician to know the diagnosis. It's a breast imaging reporting system. BI-RAD 0, where there is an incomplete assessment, you need an additional imaging like a compression, ultrasound, or MRI. BI-RADs 1 and 2, it's negative or benign etiology. 3, it's a probable benign where you need a follow-up 6 months interval, 6 in 1 year. BI-RADs 4, it's suspicious low grade. It divides to BI-RADs 4A, B, and C with higher suspicion. BI-RADs 5, where the lesion is a highly suspicious for malignancy. The problem is BI-RAD 6, biopsy-proven malignant lesions. BI-RAD descriptors help predict the risk of malignancy for the calcifications. For example, the coarse heterogeneous is around 7%, amorphous 13%, fine pleomorphic around 29%, and fine linear is 53%. The workup management strategy, the standard workup follows a tried approach based on the BI-RAD assessment category. In this vicious screening finding, utilize magnification images 90-degree to clarify the exact shape, the morphology, and the arrangement distribution of these calcification. Then assessment descriptors, the morphology, whether it's linear, 92%, while punctate or round has a typical appearance. The distribution, if it is segmental distributed, pointing towards the nipple, definitely has a higher suspicious, being ductal carcinoma in situ, whether diffused or scattered pattern, typically benign. Advanced imaging problem solving like ultrasound used primarily to check an associated mammographic occult breast carcinoma or masses. Other modality includes contrast-enhanced mammography, provide vascular information. The presence enhancement significantly increase suspicious of malignancy. Tissue biopsy includes stereotactic vacuum biopsy, preferred method for microcalcification, allowing larger tissue sampling, crucial as a standard gauge 14 core biopsy. And then specimen radiography mandatory after the biopsy to confirm that the targeted calcification were actually retrieved. This is the image-guided biopsy, the stereotactic core biopsy used to obtain the specimen microcalcification done in two approach, whether prone or upright approach. It is done mainly for suspicious microcalcification, but can be done also or performed for masses, asymmetries, architectural distortion not detected with ultrasound or other modality. If multiple suspicious findings are present, biopsy of many targets should be performed. Vacuum assist biopsy is adjunct to core biopsy is required to achieve a higher as a possible non-bites the much larger tissue specimen needed by pathologists to make the definite diagnosis in borderline cases. It is performed in 3 dimensions, X, Y. The additional dimension here is the Z, the depth, the third plane, the lesions to be determined. So localization will be very accurate. Going through the procedure, workflow, first you position the patient, whether upright or prone position, then you obtain stereotactic imaging, the typical plus and minus 15 degrees, then you, with a larger core needle, then you take images, a specimen radiograph, collecting tissue to obtain the calcification, then you deploy your marker, and this is essential for a future reference, especially if the results are malignant and surgery is required to locate the same area. This is the prone, the both types of prone and the upright, where the patient in this position has a greater risk for vasovagal reaction, but however, it is helpful. Here is the vacuum assist biopsy using introducing in a prone patient to obtain the microcalcification after obtaining the local anesthesia. This is a case with a focal asymmetry and suspicious calcification. Starting stereotactic biopsy, localizing the 2 images stereo pair plus minus 15. This is the core, the scout images pre-firing, and this is the post-firing where the core here is open to obtain the calcification. And this is the sample obtained after firing, taking the imaging to confirm the presence of the calcification within the sample. Otherwise, you need to obtain more images. After obtaining the images, then you need to deploy the markers in all the place of the biopsies, and you might use a different shape markers, which will be helpful for the surgeons later on to do a local excision with wire localization. This calcification proven to be invasive ductal carcinoma, so a wide localization done, a therapeutic wide excision for the specimen, and the X-ray showing a small group of microcalcification representing ductal carcinoma in situ centrally within the excision, and approximately there is 1 to 2 cm excision margin seen free radiological. So this is the typical approach when we proceed with BI-RADS 4 or 5 suspicious findings. If it is benign, then follow up. If it is a high risk, you need to do open biopsy, if not repeated. If malignancy, you will continue therapy. If biopsy is not sufficient, which is very rare, then you need to do rebiopsy again. The management strategies for based on the result, if the result is concordant benign, the benign tissue matches the imaging, then your next step is to return for routine screening or follow-up. If the result is discordant, imaging looks suspicious, but the pathology still, it's a benign, this means it is discordant, then you need to consider rebiopsy or surgical excision to prove the diagnosis. And if the result is a high-risk lesion, like atypical ductal hyperplasia, the abnormal cells may be hiding another cancer in the future, then surgical excision to be considered. If it is malignant, DCIS, or invasive component, then cancer is confirmed. You need to start management, and patient will be referred to the oncologist. In conclusion, the screening mammography is the only imaging modality that has been proven to decrease the breast cancer mortality for a general population. Breast mammograms calcification is a synthesis of morphology and temporal stability over time. The ultimate goal for radiologists' conclusion is to assign BI-RADS score, which dedicates the management strategy. Confidence in benign concordance, image-guided core needle biopsy findings allows avoidance of unnecessary surgery. Authors have confirmed the accuracy of core needle biopsy, demonstrating excellent histologic agreement between the core needle biopsy and excised specimens. Sample error can lead to histologic underestimates. A careful view of pathology results with recommendation for excision of the lesions known to be subject to upgrade, like atypical ductal hyperplasia, is necessarily discordant between imaging and pathological excision.
Good morning, everyone. I am Dr. Shashikala Gurappa Hiremani, Head of the Department of Pathology. I am from Taluka General Hospital, Baswan Bagewadi, District Vijaypur, and I am from Karnataka and India. Earlier, before 1 year, I used to work in the District Hospital, Vijaypur. So today I am here to present a topic on atypical presentation of follicular thyroid carcinoma, a rare case report. Coming to introduction, about 10 to 15% of all the thyroid tumors are follicular thyroid carcinoma. So second most, it is a prevalent kind of differentiated thyroid cancer, typically manifest in the 5th and 6th decades of the life, and it is more common in the women. Below 45 years of the age, the incidence lies below 1% of the this one. It frequently invades the blood vessels and spreads hematogenously to the distant location, usually to the lungs and bones. According to reports, the frequency of the distant metastasis ranges from 6 to 20%. Early detection, timely intervention, and regular follow-up play a crucial role in improving the prognosis and prolonging the survival in follicular thyroid carcinoma patients. About 80% of the patients diagnosed with any type of differentiated thyroid carcinoma responds to total thyroidectomy or levothyroxine and the radioiodine 131 ablation. However, unlike papillary thyroid carcinoma, follicular thyroid carcinoma often presents with benign appearing features on ultrasound, leading to potential misdiagnosis as thyroid follicular adenoma, which complicates the treatment decisions. Fine needle aspiration also has limited diagnostic accuracy due to the lack of specific cytological markers for the follicular thyroid carcinoma. Diagnosis is typically confirmed through histopathological examination, emphasizing the vascular and capsular invasion. However, inadequate sampling or the absence of the clear invasion foci can result in missed diagnosis. Consequently, a combination of morphological assessment, immunohistochemical analysis, and molecular pathology is often necessary for an accurate diagnosis. This presents a case of patients with follicular thyroid carcinoma exhibiting cervical lymph nodes metastasis, but no distant metastasis, diagnosed exclusively through fine needle aspiration cytology. This coming to case report, this study was done according to the care guidelines at District Hospital Vijaypur in the month of March 2025. A 45-year-old female presented with a diffuse swelling over the neck. I'll show you in the figure 1. Since 2 years, initially the swelling was left side of the neck, measured 1 into 1 centimeters, but had progressively increased in size over the past 30 days, reaching 6 into 4 centimeters, diffusely involving the right side of the neck also. The swelling had previously been asymptomatic, but the patient recently developed difficulty in swallowing. There was no history of fever, weight loss, or heat intolerance. On clinical examination, the swelling measured 7 into 5 centimeters, involving both the lobes of the thyroid. Left lobe swelling was measuring 4 into 3 centimeters, right lobe swelling measuring 3 into 2 centimeters. Both hard in consistency, were mobile with reglutination, and no local rise in the temperature. Left and right cervical lymphadenopathy were present. The largest left lymph node was measuring 3 into 2 centimeter, and it was hard in consistency. So this is the figure showing the patient came with the history of diffuse neck swelling. So investigation done, a thyroid function test revealed normal results. Patient is subjected for the ultrasound, neck ultrasound, demonstrated an enlarged left lobe thyroid measuring 4.8 into 3.6 into 4.4 centimeters with a hypoechoic nodule measuring 3.8 into 3.2 centimeter, completely replacing the thyroid parenchyma and containing macrocalcifications. Enlarged right lobe of thyroid measuring 3 into 2.6 into 2.4 centimeters with hypoechoic nodule measuring 1.66 into 2 centimeters with 4 colloid nodules of each size measuring 0.4 into 0.5 millimeter. Few large enlarged left and right cervical lymph nodes shows central areas of necrosis, but there was no conglomeration is noted. And patient is also subjected for the fine needle aspiration cytology, and it was performed in Department of Pathology, District Hospital, Vijaypur, on left lobe of the thyroid, right lobe of the thyroid, and largest left cervical lymph node swelling. The FNAC from left-sided thyroid lobe swelling yielded blood mixed material, and from the largest left cervical lymph node also yielded very scant blood mixed material. However, from the right lobe of the thyroid swelling produced pale, brownish, thin colloid-like material. Microscopic findings from the left lobe of thyroid swelling revealed hypercellularity smears with micro and macro follicular small clusters arrangements. Cells were pleomorphic with high NC ratio, nuclear cytoplasmic ratio, showing 2 to 3 nucleoli and nuclear overlapping. The cytoplasm was scant with irregular borders seen in no colloid and necrotic background, as figure shown in the 2A and B. So this is the figure showing 2. Left side you can see that it was a MGG stains and studied under 10x. And these are here the cells are atypical. They are arranged in the macro follicles and micro follicles and in the small clusters. So in right side figure you can see here one cluster. So it was studied under 40x under MGG stain, and cells are pleomorphic. They are having high NC ratio with a prominent nucleoli with there was no colloid. Microscopic findings from the right lobe of the thyroid swelling shows small clusters and microfollicular cells arrangement with marked cellular pleomorphism with high NC ratio and scant amount of cytoplasm. Background shows scant amount of colloid, as figure seen in the figure 3. So this is the figure 3 showing the it was a pap stained smear studied under 40x. Cytology slides of the right lobe of the thyroid showing atypical follicular cells with high NC ratio with prominent nucleoli with scant amount of colloid background. Microscopic findings of the left cervical lymph node demonstrated similar findings as that of the left lobe of thyroid swelling, as shown in the figure 4. This is the figure 4 MGG stains, and it was studied under low power. And here you can see there are atypical follicular cells with high NC ratio with a prominent nucleoli. You can see background there was many lymphocytes were spread out. So diagnosis: features consistent with the follicular thyroid carcinoma with the lymph nodes metastasis. Coming to discussion, follicular thyroid carcinoma is a well-differentiated thyroid malignancy that predominantly spreads through hematogenous routes rather than the lymphatic pathways. Nodal metastasis from follicular thyroid carcinoma can occur in a variety of ways. According to estimates, nodal metastasis ranges from 4.7 to 30%. Unlike papillary thyroid carcinoma, follicular thyroid carcinoma lacks distinct nuclear features and specific cytological markers, making its diagnosis challenging. In this case, the patient had a long-standing left-sided thyroid swelling with rapid enlargement in the past 30 days, accompanied by the development of a right-sided neck swelling and cervical lymphadenopathy, raising the suspicion of malignancy. Despite normal thyroid function test, ultrasound findings of a hypoechoic nodule with a complete parenchymal replacement and macrocalcifications suggested malignancy. Staging of follicular thyroid carcinoma is done into two categories. Younger than 45 years of the age, if the carcinoma is confined to thyroid alone with the local lymph nodes involvement. And category 2, usually it is more than 45 years of age and carcinoma was confined to thyroid but with a distant metastasis. This method of staging is the tumor node metastasis and TNM method of classification. For less than 45 years age group, if the carcinoma is confirmed to thyroid alone with the local lymph nodes involvement and no distant metastasis. So our case was categorized as stage 1. In our case, final aspiration cytology from both the thyroid swellings showed high cellularity, micro and macro follicular arrangements, nuclear atypia, and scanned cytoplasm with the irregular borders along with an absence of colloid, supporting a neoplastic process. The similarity between the final aspiration cytology findings of the left lobe of the thyroid swelling and cervical lymph nodes further indicated metastatic involvement. Consequently, a diagnosis of follicular thyroid carcinoma with cervical lymph node metastasis was established. Follicular thyroid carcinoma is often difficult to distinguish from follicular adenoma based solely on the cytology, as a definitive diagnosis requires histopathological confirmation of capsular and vascular invasion. However, in this case, the presence of lymph nodes metastasis along with the acute course of increase in size of the swelling is strongly supported a malignant diagnosis. Although follicular thyroid carcinoma predominantly spreads hematogenously, regional lymph nodes involvement has been documented in a small percentage of cases, as similar to in our case. This case highlights the importance of integrating clinical, radiological, and cytological findings for early diagnosis and appropriate management. Surgical excision followed by histopathological examination remains the gold standard for confirming the diagnosis and determining further treatment, including radioactive iodine therapy if necessary. Coming to conclusion, follicular thyroid carcinoma remains a diagnostic challenge due to its overlapping features with the benign follicular lesions and its reliance on histopathological confirmation for definitive diagnosis. This case underscores the significance of a comprehensive diagnostic approach combining clinical evaluation, imaging, and cytological findings, especially in the presence of atypical presentations such as lymph nodes metastasis. Early diagnosis and prompt surgical management are critical for improving the patient outcomes. These are my references. Thank you.
Good afternoon, everyone. My name is Dr. Dunyapon Prachutham from Institute of Nutrition, Mahidol University, Thailand. Today, I'm going to talk about one-size-fits-all paradigm shift of functional food development in personalized nutrition for cancer prevention. So most part of the world, especially in Asia, has high incidence of cancer. But one thing that I like to bring attention to you is that most of the cancer is actually preventable by reducing the exposure to the risk factor. And according to the recent statistics, there are about 40% of cancer worldwide that are attributable to the modifiable risk factors. For example, the smoking, infection, and alcohol consumption. However, what we want is, of course, to avoid carcinogen from the diet and environment so that we will not get cancer, right? But in the real world practice, it's quite challenging to achieve. Too many adults are still smoke, drink alcohol, and consume unhealthy diet, which have the increased incidence of the obesity associated with many types of cancer. And the health spending is actually on the rise again. This is the post-COVID era. Over a decade for the alcohol consumption, this is a statistic comparison between 2013 and 2023. You can see that most of the country, the statistic for alcohol consumption has been steady, or in some country there are some reduction of the alcohol consumption as well. However, right now, over 2.6 million people are still consuming alcohol and die from alcohol globally. And there are about 5.5 liters of alcohol consumed per person per year. And according to the statistics from WHO, 56% of people around the world do not drink, meaning 44% of people are still drinking. So, and another interesting statistic is on the alcohol consumption among adolescents, which are keep rising. 60% of 15 years old people consume alcohol in their lifetime, and 38% of the young people consume alcohol in the last month. So what I would like to bring attention to is that avoiding carcinogen from diet and environment is essential. However, it is quite challenging to achieve in the real world practice. So the food innovation that can promote detoxification and the excretion of carcinogen is still in need. However, genetic polymorphism of some detoxification enzymes such as ALDH2 or GST has been known for a long time, right? And it has been a big challenge in designing the dietary intervention because one size does not fit all. Right now, we are entered to the era of personalized. We have personalized medicine, personalized nutrition. We try to make a tailor-made product for each person individually. So the paradigm has been shifted from the one size fits all into the personalized nutrition concept, in which we will need information from data like physical exam, nutrigenomic, metabolomic, gut microbiome, and then we can design the product that is suitable for each person. However, in terms of industry, it is not easy to produce a small lot personalized food production, right? Because it's quite costly. It requires a high investment cost. So today I would like to propose a paradigm shift again to the one-size-fits-all concept. However, we will combine with the personalized nutrition concepts as well, in which I would like to propose that the best way is to have the functional food product that should be effective in both wild type and the genetic variant individuals. And today I will show you some of the proof of concept example, which is my own innovation, functional drink for reduction of alcohol-derived carcinogen. With the pain point, of course, many people of countries around the world, we've been of socialization, right? And alcohol is one thing that people drink during the socialization with their friends or their relatives or their business partner, whatever. And once people consume the alcohol, there will be the carcinogen occur in our body, and which is the acetaldehyde, and the acetaldehyde can cause increasing of the risk for oropharyngeal, liver, colorectal, and breast cancer. The good news is that our body has a detoxification enzyme, and the main one is the ALDH2, in which it converts the acetaldehyde into the acetate. Unfortunately, some people actually including me, we have the genes, we carry the defective gene for the detoxification enzyme, which is the mutant ALDH2. And many people who have the ALDH2 mutant genes will tend to be will receive more like toxicity from the acetaldehyde than other, and we have increased risk of the cancer. So what can we do to reduce the alcohol-derived carcinogen? According to the metabolism of the alcohol, from alcohol, it can be converted to acetaldehyde by the enzyme alcohol dehydrogenase, and then acetaldehyde can be converted to acetate by the enzyme aldehyde dehydrogenase, like the ALDH. And the ALDH2 is the one that has the high incidence for the gene polymorphism. A good news is that at that time when I was interested to to develop some innovation that can help people who have the ALDH2 gene polymorphism, I came across a work which is an in vitro study by Nosova et al. Showing that among lactobacilli and the bacilli species, the Lactobacillus rhamnosus GG or the LGG, which is quite a popular probiotic organism, had the highest capacity for conversion of acetaldehyde to acetate. And the good news is that these species, they have low activity of ADH, so they will not convert alcohol to acetaldehyde, but they can help convert the acetaldehyde into the acetate. So, and this LGG is a probiotic microorganism that I think we can use it for making a fermented product. That's why we came to the solution and make it as an innovative product, which is we developed the LGG fermented milk. And then we prove of the concept by performing the randomized control trial. We asked people to consume the LGG fermented milk before taking some alcohol. And then we measure the outcome, which is the carcinogen reduction. Is it effective in both people who have wild type or people who have the ALDH2 mutant genes? And what about the duration of flushing? Because people who have the ALDH2 gene polymorphism, they usually have the flushing after consuming less than 1 glass of the alcohol. So we measured the flushing duration as well. And with the method, the objective of this study is to investigate the effect of milk fermented solely by LGG on the blood and salivary acetaldehyde of alcohol consumer with wild type and mutant ALDH2 polymorphism. So what we would like to measure are the metabolism, right? And there are some variation between individuals. So we decided that we need to use the design as randomized crossover. However, in this study, we include people with both wild type and mutant. So the population is quite heterogeneous. So we think we should use the design as a randomized block design. So with this study, we use a combined design, which is so-called a randomized block crossover placebo control trial, in which people which are social alcohol drinker, we only include people who have like occasional drink in like some party or whatever, but we do not include people who are like heavy drinker. Okay, and we divide people into 2 blocks. The first block is the active ALDH2. Another block is the inactive ALDH2, which means people who have some mutant genes. And with each block, we randomized them into a group fermented milk and placebo, and fermented milk and placebo, and then they receive the intervention, and we measure the outcome. After that, there are a watch out a period for 1 week, and then we cross the group. So at the end, everyone will end up receiving both the fermented milk and the placebo milk, so that we can compare the result between the same person. And what we measure is the salivary and the blood acetaldehyde. This study has been approved by the Mahidol University Central Institutional Review Board, and our study only conducted like during the weekends, which is not the working time, okay? Because we need to ask the subjects to consume the alcohol as well. The inclusion criteria include healthy Thai males aged between 20 to 50 years with normal vital signs like no systemic diseases. They have normal blood biochemistry, especially the CBC, liver, kidney function, lipid, and glucose profile. And there are some people with wild type and some people with the mutant, and no history or problem with when consuming milk, because our intervention is the milk. And with alcohol consumption is moderate, which is less than 2 drinks per day, and able to consume the intervention, able to avoid other probiotics product during the study. And with the exclusion criteria, we exclude people who smoke, people who drink alcohol during the week before the test day, people who have liver diseases, who have gastrointestinal surgery, who have been in alcoholism or alcohol abuse, and people who take the medicines affecting the alcohol metabolism. These are the exclusion criteria. And here are the participant flow diagram. There are 41 people who assess for eligibility, and then after the screening, there are 20 people who were randomized in this study. And luckily, everyone adhere to the protocol and stay until the end, so there are no dropouts, and we got complete data from all of the participants. With the ALDH2 polymorphism, there are 33 people who passed the inclusion criteria and then underwent the RFLP, which is the restriction fragment length or polymorphism test that we use to identify who is the wild type, who is the mutant one. And what we found is that 11 men, they are heterogeneous mutants. We did not find the homozygous mutant. We only found the heterozygous mutant. I think it's because like in Thailand, most of Thai people right now, we are like mixed heritage, right? And there are many people who are Chinese inherit and mixed with some Thai. That's why most of people here are like heterozygous mutant rather than the homozygous mutant. And here are the result for the RFLP that we can see the heterozygous mutant is like this. We usually see like the fragment and also the remnant. And with our study, we start by asking people to consume the milk, and the placebo one is a lactic acidified milk, and the fermented milk contain 10 to the 8 CFU per ml of the microorganism. And what we do is that we ask people to consume the milk, and then within 5 minutes, and then we ask them to consume around like 5 glasses of beer, which contain 0.4 gram ethanol per kilogram of their own body weight. So different people may have like consumed differently according to their body weight, but we divided them into like 5 servings of the glasses. And then after finish alcohol drinking, we measure for the salivary acetaldehyde and the blood acetaldehyde. We also perform the breath test to measure the alcohol, and do the blood collection and saliva collection to collect data. And for the alcohol exposure, you can see here that at baseline it's very low, right? No, it appears after finished meal there are no alcohol in the blood or saliva. But then after 3 glasses of the beer, of course, there are alcohol occur in the blood. And with the LGG meal and placebo meal, there are no significant difference. What does it mean? It means that the LGG meal has no effect on the blood alcohol level. And the LGG milk can stay in the mouth. Imagine we ask them to consume the milk and then they consume the beer as well. So they are all liquid, right? But the good news is that the microorganism is still can stay in the mouth. So we measure and found that it can retain at least 3.5 hours in the mouth after the milk consumption. So this is quite good because in previous study, people found about LGG colonization in our colon, but no one has shown the LGG colonization in the mouth before. But this one can show that at least 3.5 hours they can stay in the mouth. And with the biomarker of outcome, we check for the blood acetaldehyde after the milk consumption. And what we found is that the LGG can reduce the blood acetaldehyde in both the wild type and the mutant significantly. You can see that this is the area under the curve. The gray one is the area under the curve for the placebo group, whereas the black one is the area under the curve for the LGG milk intervention. You can see it's the same similar pattern between people with wild type ALDH2 and the mutant ALDH2. And with the duration of the flushing, the one with the redness of their face and their body, we found that with the LGG milk, the duration of flushing has been decreased significantly. And the response is 100%, which means like everyone, regardless of the ALDH2 status. For the salivary, the result is quite consistent. The difference is that for the wild type, salivary acetaldehyde, they seem to be decreased with the LGG milk, but it's not statistically significant. Whereas for the mutant one, is significantly reduced with the LGG milk consumption. And the salivary response in the mutant one, in the mutant group, seems to be better than the wild type group. But anyway, in conclusion, you can see that with the blood acetaldehyde, with the blood acetaldehyde, the intake of lactobacillus rhamnosus GG fermented milk before drinking the alcohol can reduce the blood acetaldehyde level and the duration of flushing in the occasional drinker with both wild type and heterozygous mutants. So here is the summary. And the application of this work is that this is a proof of concept showing that it can be possible to make an innovation that can fit all. You know, it can be working with either wild type ALDH2 or the mutant ALDH2. And this may have implication for cancer prevention and reducing the risk of the accidents associated with the alcohol drinking and the hangovers. Okay, thank you very much.